I want to welcome all of you to today's briefing webinar on peer-to-peer learning, focusing on wastewater surveillance and bioinformatics. This is the second phase of Project Stellar, focusing on sustainability, aimed at institutionalizing systems to strengthen laboratory systems towards sustainable laboratory diagnostics. Next slide, please. So a brief on the history of Project Stellar, which started in 2021 with the key goal to catalyze COVID-19 investments, more so focusing on 23 countries, which were lagging behind in the WHO testing targets. With subsequent improvements in the COVID situation, Stellar redeployed its resources toward strengthening of integrated laboratory systems core capabilities. This has seen two phases of reinvestments, with the first one happening in November of 2023, where the scope of Stellar was expanded to include additional 9 new cohort countries, with the goal of expanding on lab system strengthening activities, as well as scaling up of wastewater surveillance. And the last reinvestment again was in April 2024, April 16th, 2024, where we got an extension approval to support sustainable knowledge transfer through a multi-country peer learning. And that is part of the approval that really supports the peer learning model under which wastewater surveillance and bioinformatics is nested. Some of these proposed activities build on Project Stellar I investment areas and aim to promote innovative solutions to identified challenges at country level, and ultimately aims at moving away from international technical assistance to use of regional existing capacity within the African continent to ensure we're ultimately able to achieve lab systems maturity. Next slide, please. In terms of some of the key achievements realized from Project Stellar, this is mirrored to the Global Fund RSSH indicators. You can see a number of them on the screen. I'll not read each one. And these are actually centered around policy and governance, data systems, broader lab systems, quality, as well as surveillance, which is very core to supporting wastewater surveillance and bioinformatics, as well as next generation sequencing. You'll be able to read this in details when the slides will be shared with you. Next slide, please. In terms of integrated lab system strengthening investment labs landscape, Global Fund has invested a total of $563 million on lab systems since 2021. Out of this amount, COVID-19 response mechanism investments account for 58% of the total investments. You can see on the chart on the left, the amounts allocated in GC7, GC6, as well as C19RM. And this do demonstrates that Global Fund places high priority on supportive services to enable efficiency and effectiveness of diagnostic services. Of these investment amounts, specimen referral systems, lab information systems, as well as laboratory governance and management have generated a consistently high demand throughout GC6, C19, as well as GC7. We can also see that lab-based surveillance, where lies also the wastewater surveillance, through COVID-19 has also generated significant demand for surveillance, both in C19RM as well as in GC7. Other intervention areas include supply chain systems, as well as network optimization and geospatial analysis. Next slide, please. Then to sustain a knowledge transfer through the multi-country peer learning, the key goal is to enhance collaboration through uptake of proven best practices in countries which have shown exemplary performance in the intervention areas of interest, with the key objective of achieving sustainable laboratory systems and diagnostic networks, while leveraging on existing and established regional capacities to promote peer learning, as well as the twinning model. Selection of countries is based on either being tier 1 or tier 2 cohort countries, or countries reporting on the relevant interventions. EXA is tasked with coordinating this activity and has extensive experience in leading multi-country grants of this context. Next slide, please. Key priority interventions are primarily 5, with a focus on wastewater surveillance and bioinformatics, that is in row 4, where South Africa will be the mentor countries, while the mentee countries are 3, that is Nigeria, Gambia, and Ghana. Burkina Faso is not part of the list. And the implementation model includes country and field visits, hands-on training, technology transfer, virtual mentorship, as well as establishment of communities of practice. Next slide, please. How will success be measured? As I've said again, EXA will facilitate and coordinating the peer learning and will facilitate participants' travels, per diems, and any travel-related expenses, while mentor countries will provide the supportive training environment to the mentee countries with the 2 possible rounds of visits during the training sessions. Each round will be composed of a maximum of 3 participants per country. But in this case, we only have 3 countries, so NICD South Africa will be able to accommodate all the 9 participants in every visit. The intention is to have the peer exchange visits ending in Q1 of 2025, but ideally by December of 2024 to allow more time for implementation and monitoring of progress. The mentor country, that is NICD South Africa, will also be able to visit the mentee countries and provide follow-up support to these countries, and these support visits will end by Q4 of 2021. Measures of success will include improved lab systems core capabilities reflected on SPA and JEE, improved engagements between principal recipients and lab directors to enhance implementation as well as ownership. And it is also expected to strengthen collaboration and foster relationships and create better networking opportunities amongst laboratory leaders in the continent. We expect also to do a pre and post training assessment so that we are able to track progression of achievements. Next slide, please. I do believe that should be my next slide. And with that, I would want to welcome Dr. Muklid to walk us through the presentation by the South African team, giving a high-level planning of the mentorship approach, as well as planning and scheduling of activities and the timelines. Thank you. Kindly skip that slide to the South African. Good, there we go. Muklid, please welcome.
Great, thank you, Osman, and thank you for the invitation. Good morning, everyone. My name is Muklid Yusuf. I'm the co-director and the principal scientist of the Wastewater Genomic Syndicate at the Center for Vaccine Immunology at the NICD, the National Institute for Communicable Diseases in South Africa. I'm here today with my colleagues, Dr. Kerrigan McCarthy and Bongi Aposa. Today, I'm going to try to describe our plans for, thank you for this, trying to describe our plans for the next 18 months or so, about what we plan to do with the countries that we are agreed with Global Fund to do the peer-to-peer learning. So in my presentation or the overview, I would like to present being part of 2. The first is I would like to show you what we have been doing in the past 3 years or so in terms of wastewater surveillance. How did it started? What was the methodology we used? What experiences we have generated? And what are we doing currently? And then in the second part of the presentation, I'm going to speak briefly about what are we proposing to do. Next slide, please. So this is just to show the beginning, where we did come from as institute and as a country in terms of wastewater surveillance. Everything started from polio, and probably some of you have also some activities doing wastewater surveillance for polio, since the WHO has established the polio surveillance using environmental surveillance back in 2014, or adopted at that time. So in 2017, it's where the NICD as the WHO reference laboratory has adopted the use of the ES, or environmental surveillance, to monitor the spread of polio and towards the eradication of the virus. In May 2020, when the COVID hits the world, we at the NICD decided to try to confirm or to establish the concept of detecting the SARS-CoV-2 in wastewater. And that's after some other countries, particularly from the Netherlands, confirmed the presence of the virus in wastewater. So soon after that, we've done some testing, pilot testing, to confirm the same principle, since we have the expertise and the facilities to do wastewater testing. Then in January 2021, the MRC, the Medical Research Council of South Africa, published that proof of concept as well. And then we received, in the same year, in March, we received the first grant from the Water Research Commission to start doing some activities in the countries. A lot of activities throughout the time. I don't want to go through each one of them, but the major ones was receiving funding from the Gates Foundation to establish the national wastewater surveillance network that we are currently working. And today we're working in the vaccine preventable disease. Next slide, please. So what we started with, we established this, what we call it the SASIX, which is the South African Collaborative COVID-19 Environmental Surveillance. It was comprised of 95 large wastewater treatment plants across the South African metros. There was about 7 laboratories that compose of this network, and the idea was to determine the levels of SARS-CoV-2 in the wastewater treatment plants, and also to do sequencing to the virus to identify the variants circulating at the time. Next slide, please. This is the overview of the method we use. People from labs will be interested to look at this carefully. So there are a few components of the procedure, or the algorithm, or the workflow of what we do. It all started from the collecting of samples, and there are a variety of samples that you can collect it from wastewater samples. The most easy one, it's called grab sample. And basically, you bring a packet, and then you just grab that packet into the wastewater treatment plant, and then you pour it into these bottles, and then you ship it to the lab in cold chain. There's other method that you can use that I have not highlighted them here, but they have some difficulties, I would say. There's also something called the composite sample, which is basically you have to use an auto sampler that collects certain volume of the wastewater, pour it in specific bottle, and then at the end you come and combine each of those. The difference is particularly just talking about the time, because here you're collecting one volume from one specific time, while the composite samples, you're basically collecting sample each hour or each 2 hours, so it's more representative. But in terms of logistics, it's hard. And in the African setting specifically, I would presume it could be the same like in South Africa. It's hard to leave it unattended in the communities. The second part of the methodology, the viral concentration, is also very crucial, because different pathogens partitions in the wastewater sample in different ways. Some of them will be present in the supernatant, some of them will be present in the sludge. So to understand the properties of the virus, of the pathogen that you are working on, is also important before you decide which method that you're using. I mean, ourselves, we started with filter concentration method called Centricon in this picture, but at this stage, we are trying to move away from it to a beads-based concentration method called the MagMax. Then the third part is the nucleic acid extraction, and luckily we have now some suppliers, some companies started doing extraction kits specifically for wastewater samples. And then the fourth part, you do the PCR to detect your pathogen. And if it's positive, then you quantify the level of that pathogen, or you do sequencing to identify what variant or genotype circulating into this sample. Next slide, please. So what we have been doing in SARS-CoV-2 in the early days is basically we firstly detect it, so we were able to say the sample has with SARS-CoV-2 in it. But then very soon after that, we realized that all samples, because that was like in the middle of the pandemic, all samples tested positive. So the testing of qualitative has no meaning because all samples are positive. So what is the point of testing? The idea was coming after that to say, let's do the quantification. Let's see what level of SARS-CoV-2 in that sample is, and how can we correlate this with the levels in the patients or in the community in the patients. So in this graph here, in the graph to the right, you can see simple standard curve. And to the left, the algorithm is the same algorithm I described in the previous slide. But here, the x-axis will be the quantity that we have detected, which is it could be, if it's qPCR, it will be CT values, and then in the y-axis it will be concentration using specific standards. Next slide, please. And then here, the important thing here is to correlate this to what we have from clinical perspective. So I'm going to describe this in detail. The left axis is the number of lab tests has been confirmed. So it's a number of clinical samples from specific area of a specific district or metro, showing in the y-axis to the left. And the bars are basically the number of lab of that confirmed clinical cases. The x-axis is the epidemiological week, and the y-axis to the right, the y-axis to the vertical right, is the log copies per mil. So after we determine what is the copies per mil, then we got the log of that of SARS-CoV-2, and then the circles with the different colors are basically the different wastewater treatment plant sites. So what we say in here, we say you can easily see the correlation between the higher number of log copies per mil compared to the high number of clinical cases. If you look specifically, unfortunately, I can't highlight, I'm not showing the slide, but if you can look at 2021 EpiWeek 22 to EpiWeek 31 in the middle, basically, of the slide, you will see high number of clinical cases and also high number of log copies per mil of SARS-CoV-2. And then before that, you will see also low cases of genome copies per mil and low cases of clinical. So you can see this is a correlation very easily. You can make interpretation and see that the correlation between wastewater data and clinical data. Next slide, please. And here, what we can show the evidence of how this was useful. In the first top graph, this is exactly happened in EpiWeek 19, 2021. And that was before the Delta, the third wave of infection, the Delta variant hit South Africa. So we saw that there is an evidence of increasing the level of the virus in wastewater. And then soon after that, we saw it in clinical setting. The bottom graph, which is showing it in before the Omicron, the fourth wave infection, shows similar thing, and you'll see this in the green box. Next slide, please. So the previous slides were talking about the quantitative one. What's the important thing about talking about the quantitative of SARS-CoV-2 in the communities and how it will be useful, how it was useful basically to monitor the disease progression from wave to the next wave. Now since COVID-19 or the SARS-CoV-2 itself has not been tested in the communities as it was, wastewater surveillance will be a really crucial tool to monitor the spread of the virus. If there is not enough health testing in the communities, or this health-seeking behavior has changed. Talking about the sequencing, it's also important because you need to understand what variants circulating, whether it's beta, whether it's delta, whether it's Omicron, the current one, and then the sub-Omicron that we currently have. And from wastewater, we started all this from firstly doing sequencing of the wet lab, which is basically we adopted the same methodology that has been described by the Arctic protocol that was used for clinical samples, using the Illumina COVID-seq test that has been also designed by the Illumina company. And then after that, we used a number of tools, a number of bioinformatic tools. And I think this is what we're going to be providing as part of this mentorship. So one of them is called the Galaxy. The Galaxy, it's a free online tool. We haven't designed the pipeline, but we used the pipeline that have been designed by other colleagues. And then we use the Galaxy pipeline to analyze our data. And then after that, we generated heat map, which can show us the different changes happening to the virus from the sample. And we also establish a way of looking for different variants using signature mutation analysis. And then eventually we got to collaborate with colleagues from the United States, from Scripps Research, where we then use their tool called Freya tool. And it does the same principle, but everything is using command line. And eventually you have also this graph to the right bottom, that's showing the different lineages circulating at the time. Next slide, please. I think we can move to the next slide. This is the same thing, showing the sequence output. And here it's this is important in terms of trying to understand, can we use the wastewater surveillance as an early warning system? So the heat map here is showing, although this has been done retrospectively, not prospectively, but here we showed that some mutations that could appear in the viral sequences from wastewater samples before those mutations could be observed in clinical samples. The reason we cannot call them variants, because in order to call any new sample as specific variant, you need to have it. There's a certain criteria that has been detected in clinical sample, in a certain number of patients, in certain geographical area, and should have certain number of mutations. While in wastewater, we don't generate consensus sequences. That's the first thing, and it's really difficult to establish whether this is a variant or not. But what we can establish to say these are mutations that have been detected in that specific sample, and therefore we can raise alarms to our colleagues in the public health to say, you need to maybe monitor this more carefully. And again, during the training, we were going to talk about this in more details. Next slide, please. So that was the end of our call it phase one. And from that, it was our wastewater was focusing on SARS-CoV-2. We managed to publish 2 papers. We managed to have the dashboard, and that I'll be happy to share the details after this meeting. And then we also managed to have a weekly report that we generate on an ICD website. And we also have some work that we have done with in social media. Next slide, please. So in the next, I will just going to describe what we are doing currently in terms of developing epidemiological-based surveillance for vaccine-preventable diseases. The idea came from the fact that after the SARS-CoV-2 reached its peak, when we have no more cases being detected in clinical setting, or we will reach the herd immunity, we start thinking about how can we use wastewater surveillance for other pathogens. And our own interest as a lab, as an institute, as a country was towards vaccine-preventable diseases. So we chose measles, rubella, influenza, hepatitis A and hepatitis E. And we started, number one, the first one to the left, to optimize the lab methods, validating. We use digital PCR, but it's not necessarily going to be the same that you're going to use for the training. We can also use qPCR, and then we validate different concentration methods. And then the second one in the green in the middle, we detected and sequenced the virus from wastewater samples, and we start doing some modeling to develop the burden of disease in the community. And then the last is, how can we make all this? What is the question of what does that mean? How can we maintain this network? How can we integrate it to the bigger picture, the clinical and clinical surveillance picture? Next slide, please. So we started firstly by increasing the network that we have in, and we had 2 components of our network. The first one, we call it the national surveillance sites, which is 28 sites throughout the country. And then the second one is called subcatchment, which is only in the high density populated area, which is Gauteng province in the middle. And you can see the other picture here in the middle showing the Gauteng province with 3 cities, Johannesburg, Tshwane, and Ekurhuleni. And we have 18 sites in total in this province. Next slide, please. But I forgot to mention that the most important thing about these sites that you should have all the details about population size and other environmental information as well. So the idea in general was to build evidence to policy pipeline, wastewater surveillance for vaccine proximity disease, and comparing with clinical surveillance. So the question is, the question of lab was answered at the time because we know we have validated the methods, we know how to do the testing, we know how to do the sequencing. We use the same approach we use for SARS-CoV-2, everything is working. The question comes after that is how can we interpret this data, whether it's positive or negative? So the first thing we did, if you look at the box to the left, it was positive versus negative ES results. So the negative results, and that's what we have established, the negative results cannot exclude that it could still be present. And the idea was we will not try to work on a fact that let's validate the methods in terms of sensitivity, specificity, and so on. But we would like to work from epidemiological public health angle. So a negative result cannot exclude that it can still be present. But a positive result in a specific wastewater sample in a specific area with negative results from clinical side, that means something. And that will probably then have to lead to public health action. And this is what we wanted to do. So we have established what we call it discordance comparison between samples, between results, from clinical and wastewater. And we also establish a weak district result for each of those. So we will identify one epidemiological week and one district, and then look at the clinical data that we have and look at the wastewater that we have. You can look at the last table in the left box, where it says if it's positive from clinical and positive from wastewater, it's positive, so it's concordant. And if it's negative, it's also concordant. However, if it's negative in clinical sample and positive in wastewater sample, it's discordant to the advantage of wastewater. And this must be something, this must be action from public health. If it's discordant that it's negative in wastewater and positive in clinical, still discordant, but the public health action is going to be happening anyway because the clinical sample tested positive. Now, if you look at the left, the right box where we talk about what I have been describing in each pathogen. So, for example, measles, they were about 2.7 concordance. There was about 2.9, concordance, 2.7, there was discordant, but it was positive for wastewater. And again, this is where the this is where the public health action needs to be done. 19% for rubella, we have in the same category, and 4% for Hep A, 24% for Hep E. Influenza was a bit tricky because we were using it in a different way because we had different season transmission comparing to the other endemic disease. Next slide, please. So this is more details in terms of what was happening in measles. And in the top graph, you will see this is just percentage of samples that are positive per epidemiological week. And just to say, in South Africa, we had a very long outbreak occurred in the end of 2022 until end of 2023. There were actually 2 outbreaks of measles, one imported from another country and one locally. Unfortunately, we start testing our measles samples only after the towards the end of the outbreak. So that's why the data were not going to be correlated nicely. We also, in all our optimization, we use what we call them the detection of limit or detection of quantification, whereby we got a control and we try to prove that whatever we are detecting is sensitive enough. And here in this box in the middle, you can see the one I highlighted in red. It was saying 13 samples tested positive for wastewater and negative for clinical sample. Next slide, please. This is similar to what I have described in measles, but in rubella. And we know rubella and measles always go hand in hand. And there were about 19 samples, 3.9% were tested discordant, tested positive for wastewater and negative for clinical. Next slide, please. Hepatitis A, influenza A and B. So what have been achieved here is basically to try to, as I said, to establish the same thing in terms of the methodology, but because the influenza has a different pattern comparing to the other endemic diseases, hepatitis and the measles and rubella, we use a different approach, which is, it's not the same approach of concordance discordance in this case, because of the fact that influenza spread only during a specific season. So the comparison was a bit different. And in addition to that, what we found, which is something very interesting, is the storing of influenza samples and then testing influenza for those after with few months has compromised the sample. So that's something that we were going to discuss about how can we store the samples, and whether we should also talk about the concentration techniques that we're going to be using. Next slide, please. Hepatitis E, we were surprised to see the hepatitis E data, and the reason is in South Africa we don't have clinical surveillance for hepatitis E. We use data coming from the National Health Laboratory Services as a diagnostic tool only, and most clinicians do not send patients for testing for hepatitis E. And even if they do, it will be only until the patients are really symptomatic, becoming jaundiced. And the other thing also in hepatitis E that makes it complex, that is a zoonotic infection as well. There are some genotypes also being prevalent in animals. So from wastewater samples, especially if you have an open manholes, you wouldn't know where this is coming from. So a lot of to do still in hepatitis E. Next slide, please. And here's hepatitis A. It has a similar story like hepatitis E as well in terms of clinical setting. But what we'd like also to do is to try to compare between the two viruses, in the clinical setting and the wastewater in specific communities when we have more concrete clinical data. Next slide, please. TB was one of the vaccine preventable diseases we decided to go, although it's not a virus as the rest of the panel that we are doing. So what we're starting with now is basically we're still trying to prove the concept of getting the best extraction method and getting the best PCR method. What we're doing now is basically trying to, first of all, try to identify what is the best sample with a supernatant or sludge, and then what's the best PCR that we should be using for that. So there are two PCRs. There's one is not specific for MTB, is for all Mycobacterium complexes. And then we wanted to use another another MTB specific primer set to be able to identify. So we are still in the proof of concept stage also for that. Next slide, please.
To conclude, sorry to interrupt. Do you mind fast forward to the plan? Some of the technical details are good, but could be discussed during the exchange visits. Thanks.
Okay, I can do that quickly. So in this slide, it's not that much here. We're just talking about the informal settlement, which is, I believe, it's also going to be similar situation in other African countries. We're going to talk about how can we collect samples from the informal settlement. Next slide. Yeah, it was basically, Osborne, you were in time. It was just a second last before coming to the proposed mentorship program. Here, briefly, I'm going to describe what we plan to do. Next slide. So we have what we call it the preparatory phase. So, sorry. What we're trying to say here is we wanted to lay the technical foundation to make NICD and the other countries are having the enough capacity to fulfill the planning phase objectives. So in this graph, you will find activities to the left, and then to the right side, you'll find a timeline. And I didn't specify what month that's going to be because we're still not sure when exactly we're going to start, but we plan to do this in 12 months. So the first 3 months is going to be for this phase, the planning phase. And the first thing is going to be to procure the communication tool for all of us, the 3 countries and ourselves, to make sure that we have the best communication skills in terms of laptops, softwares like Zoom and others. And then the other thing, what we wanted to do is to develop the wastewater environmental surveillance baseline assessment tool. Now, this is something that we're going to establish, and then we're going to share it with our colleagues. The idea of the baseline assessment tool is to understand what are these institutions, NHPIs in these countries have, whether it's lab, whether it's EPI people, whether it's wastewater treatment plants, whether it's logistic of sending samples, everything. And because it's not a clinical study, because it's a wastewater study, that's why it has more logistic compared to what we always used to do. So we will establish this, we will develop that baseline, and then we will discuss it, assessment tool, and then we'll discuss it with our colleagues, and we'll see what is the best way to complete it in order for the other countries then to start procuring what they are needed, if they need it, if there are gaps, and if there are no gaps, then we can start. Then what we will do is a preliminary virtual introductory and to follow-up meetings to share visions and strategic overview and initial steps. So I believe we will have something like these meetings with each country in maybe more time. And then we will conduct that baseline assessment, and then we'll discuss the finding in the third month, and then we'll start procurement reagents and consumables. Because after the assessment, then we can start the procurement, because there might be need for some equipment, or it might just be the consumables and reagents. Next slide, please. So I specifically decided to put this slide to explain what I mean by the baseline assessment, although I described it just now. But for example, in terms of sites and samples, we wanted to know how many wastewater treatment plants in this country, how many manholes, or not how many manholes, obviously, but I mean, how many sites we should be focusing on, what is the population in each site that's going to be there, and then we should decide what is the best method that we should use for sampling. Then it comes to the laboratory, we will do assessment to know what is the equipment that's present in the lab, whether it's PCR, hoods, sequencers, anchor equipment, answer equipment, consumables, reagents, and so on. And then the data infrastructure. Do you have a server in your lab or institution where you can store your FASTQ files after sequencing? What is the internet speed that is in that lab or in that specific institution? This is very crucial because some of the tools are going to be online tools. What are the pipeline and tools that are available? What is the computers, laptops that are present? So all this is going to be done during the assessment. It will help us to understand what is the capability of the people that we are working with, and it will help the people also on the ground to understand whether they need something that they are not aware that they are needed. Next slide, please. Then the planning phase is basically to finalize what we have been talking in the first slide, which is the procurement. And then we want to establish community of practice. What does that mean? I'm going to describe this in the later slide, but it's going to start from the second month until end of the training or the mentorship, because it's kind of like bringing everybody together. It's something that we're also doing now in South Africa, and in, I will say, informal way, but it's something that we wanted to formalize it with our colleagues. So we'll be happy to guide you through this and then see it happening in other countries as well. And then we wanted to develop and finalize country-specific national wastewater environmental surveillance implementation plan, and to conduct project-specific training in South Africa. That's going to be in the 4th to the 6th month of this relationship. Next slide, please. So what is the community of practice means? And I don't know why the color has changes, but this is what's blue. So in these circles, I have put in the people who are involved in wastewater surveillance. So you have your public health people that are going to be like epidemiologists, and you have your funders, obviously, and you have your communities, because you're going to collect samples from communities, so it's important to include them. And you have the environment people who are responsible for the wastewater, for the water people. And you have your policymakers for the government who are going to adopt this. And obviously you have your scientists. So all these people should come together, what we call the community of practice, and talk through the whole process and talk through what we wanted to achieve at the end, using the evidence that's going to be developed and using the learning from other experiences. Next slide, please. And if we wanted to implement strategic plan, this is what we believe, this is what we have been using now. And we found this in one of the papers from the Lancet Public Health. It talks to the policy. How do you reach the policy? So you start by primary research questions, and obviously your lab development is going to apply this to key disease in context. And then after that, it's going to be talking about the modeling and the cost effectiveness of your wastewater surveillance. And then you will do systemic review of what evidences are available. And then you develop your guidelines until you reach the policy. So this is what we think strategically we should be thinking. We might not be reached that very soon, but we have to follow the same procedure and not jump between phases. Next slide, please. What is the planning phase? Also talking about training in South Africa. That's only focused on laboratory and epidemiological training. So in the wet lab training, we plan to provide training for sample concentration, as explained earlier, nucleic acid extraction, PCRs, whether it's qPCR or dPCR, sequencing PCR. And then we plan also to train on data analysis and reporting, bioinformatics analysis and reporting. And this is going to be a crucial part to training bioinformatics. And then EPID training, which is make interpretation of what we have generated so far, and trying to develop dashboards and trying to develop weekly reports extra. Next slide, please. And then the last thing is to support country implementation in their country. So what we're going to do is to conduct, which is start from month 7 and 2 months for each country, is conduct project specific training. So what we believe usually, if the trainee receive the training in their country, it's very important. So we're going to do that in countries, and we have allocated 2 months. No, I'm not saying that training is going to be for 2 months. I'm just again, we're going to do it in these 2 months. 7 and 8 for country 1, then 9 and 10 for country 2, and then 11 and 12 for country 3. And then obviously for the entire 6 months of this phase, we're going to continue support the technical meetings and review all the procedures and laboratory results and report within the country team, and also report back to their structures, whatever they needed, to the funders or to the policymakers, and also to report back to the international meeting and conference. I will really be excited if I see some of the results that's going to come out in one of the international meetings like LOCON or any other international gathering of wastewater surveillance. And I think this is my last slide. I thank you.
Thank you so much, Mukhlid, for that wonderful presentation. Before we go into Q&A, I would want to give 3 minutes to the EXA team to give us a brief overview of the peer learning training plans from their ends. Andrew, please welcome.
Thank you very much, Osborne, and good day, everyone. My name is Andrew Silumesi from EXA, which is the East Central and Southern Africa Health Community. As EXA, we've been contracted to facilitate and coordinate the peer-to-peer learning, and we are glad that we are part of this initiative. EXA is an intergovernmental organization. I know some of you may already know the organization. Some of you may be new to EXA. We are headquartered in Arusha, Tanzania, and we comprise of 9 member states across the East Central and Southern Africa region. So in terms of our role in the peer-to-peer learning, we will be facilitating the travels, the accommodation, the venues, the transportation, as well as the monitoring and evaluation components, keeping track of the activities against the targets that we are setting, also against the background of the objectives that we desire to achieve at the end of the day. So it's a great pleasure to be part of this effort, and it's good to see what tremendous work is being done in this particular case in South Africa. And we are glad that we can have this south-to-south learning, that expertise on the continent can be shared with other countries in this manner. So we are really delighted to be part of this effort. Briefly, that is what we will be doing as part of this initiative. Thank you, and over.
Thank you so much, Andrew. And with that, we welcome any questions and comments. Alex, do you mind posting the questions we have on the chat box? Participants, also please feel free to raise your hands if you have any additional questions beyond what is posted on the chat box. The first question, please, have you evaluated the impact of chemicals in the wastewater on the results? Do you think it should form part of the analysis? I think Kerrigan has given a response to this. NICD only looks at communicable diseases. Chemical and environmental monitoring falls in another department's work on environmental health and waste management. Maybe Mukhlid, you want to weigh in with any additionals on that question?
No, I think Kerrigan has responded in what exactly I wanted to say in terms of at the NICD, it's a National Institute for Communicable Diseases. So our focus is human health from infectious disease perspective. There are definitely other colleagues in like the Water Research Commission and other institutions who are focusing into that. We would be happy to work with them, and I believe whether it's from like One Health approach, whether it's even this approach and then strategic planning as well, is to look at different stakeholders coming together. But at this training, I would say, we will only be focusing in infectious disease or communicable disease. Over.
Thank you. Then question number 2 from Kebe is any environmental wastewater surveillance for AMR? Kerrigan has stated this work is being done by another group, but you are happy to include this on your technical support. Any further comment on that?
Just to say that we're working with them, but it's still early days in terms of understanding how to make interpretation of the AMR results and also how to make the proof of concept. So it's, I would say, vaccine preventable diseases are advanced stage. And just to say, from technical point of view, it's easier to find the virus and then maybe measure the level of the virus and then sequence the virus or the pathogen, I mean. AMR is different because we're not talking about pathogen, right? So we're talking about specific mutations, specific genes with specific mutations present as an indication of the presence of the excess of antibiotic. So that's why, and even doing direct sequencing is not going to be straightforward results. So for example, this group now is doing the phenotypic assay. That's why I'm saying it's still R&D focused, but of course it's going to be part of the training as well, and we all learn together.
Thank you. Then the third question from myself, we are glad to hear that assessments will inform procurements. We know quite a number of items are planned to be procured, which can be lengthy. And Kerrigan has also confirmed that the assessment will be virtual. I think this is one key area which needs to start the EXA team in the discussions. But again, if you can weigh in with any additional details, then we'd also want EXA to comment on this, on how fast they'll be able to fast track the procurement of the supplies, because those are very key to support them at the peer exchanges. Thanks.
Sorry, Osborne, before EXA comes in, can I ask what supplies are we talking about and what kind of procurement? Because I think this procurement is more of what the country needs to actually implement wastewater surveillance. So I just need to understand before EXA can respond, what procurement are we talking about? Is it the test kits? Is it, reagents, equipment that is needed, which EXA has no... it doesn't play a role here, but it's more of the country as well as the Global Fund country team. Thanks. Maybe if you could clarify before EXA. Thanks.
Can I just clarify one thing here? So the difficulty is this is difficult to answer this question now because we need to do assessment first. Because I won't be able to advise whether the country will need equipment, whether they will need consumables, and what equipment and what consumables. I know that we need reagents, for example. But how can we answer the question if we don't do the assessment first? So we have to do the assessment. We said it's going to be virtual assessment, but we have first to develop the assessment tool itself. So simply, I need to go to the lab, our lab, that we are doing the wastewater surveillance, go through the whole lab and see this is a machine that we are using, and then put them in the list, and then share this list with the other countries, and then ask them simple, do you have this, do you have that? If the answer is no, this is what they need to procure. That's what we meant by assessment. Thank you.
So Fatim, just to chime in, there were a number of training materials which were earmarked as required, and these were also approved for inclusion in the procurements list. However, that is contingent upon the countries, the 3 countries not having those supplies. That is when EXA would be able to step in. These included a few laboratory accessories and small equipments like pipettes. Nothing major on the list, but we'll be able to share the comprehensive list. Finalization would be based also on the assessment outcomes. I hope that clarifies.
Yeah, but I think it's 2 different things. I think what's in EXA list is what South Africa will need to conduct the training in country. That is what was provided for in the budget. It's if South Africa needs to buy reagents, etc. But I think what Mohlid is talking about here is an assessment to understand what is available in country, such that they'll be able to actually implement after the training. So it's two different things. I understand the EXA part, and I don't think this is what Mohlid is talking about here. Here is about what the country has, assessing the country such that they could then advise them on what they would need to procure or not. But Mohlid can also advise on procurement of consumables or equipment, etc., that would be needed in South Africa to actually conduct the training in South Africa, the wet lab training or like laptop, etc. That is what EXA is responsible. Over.
No, absolutely. I agree with you, Fatim. We will need to have procurement from our side, but we wouldn't need to do assessment for that. If I can make it that simple. So from our side, we can tell you now what do we going to need for the training in South Africa in terms of reagents and consumables. But for the training for the other countries that's going to happen in the last phase, we can't tell you what the country is going to need and what they should go and procure until we do the assessment. I don't know if that makes it easy.
It's very clear. I totally understand. I totally understand what you mean. So what you need in South Africa, since you know it right now, this is what Osborne is saying. We need to tell EXA so that EXA can provide you the funds or the know-how to be able to get what you need. Full stop. That's different. For the country, I totally agree. You need to do the assessment first. So that it would be great if it will be done now, quickly, in 10 days, like you said, and then provide them with a recommendation of what they need to get, because that is the process that also takes time, such that we can raise this with the country team, and all of these countries already have funds already for wastewater. So it's just advising them based on your virtual assessment. These are the things you need. Let us start the procurement, and this will involve us as well as the respective country teams. Thanks.
Thanks, Fatim. Andrew, do you want to comment on how you'll manage the procurement process for the training materials?
Yes, Sure. Thank you very much, Osborne, and thank you, Fatim, for making that clarification. So what we intend to do is that we will agree with the South Africa team if we can have a meeting in the course of next week at the earliest, just to go through the way the whole program is designed in terms of what are the practical things that we require to put in place, which will include the list of consumables and other equipment that may need to be procured. From that, then we should be able to plan how that procurement will be done. But that will be informed by the details of what we get from the South Africa team. So I think that's quite clear on how we'll proceed. Thank you.
Thanks, Andrew. Can we have the next set of questions? From Kebe, how clinical and environmental samples are linked to epidemiological decisions?
Kerrigan, I think Kerrigan can answer this better than me. Over to you, Kerrigan.
My apologies, I missed the question, Osborne.
The question is how clinical and environmental samples are linked for epidemiological decisions.
Yes, thank you very much. So this is a critical question. It speaks to the reason why we are doing environmental surveillance through wastewater in the first place. So one of the questions, or the type of questions that we ask in the assessment, is also about the clinical surveillance mechanisms that are available in country. Many countries have a variety of different surveillance systems. When it comes to measles, for example, fever rash surveillance might be done across the whole country, or it might be done in sentinel surveillance sites. These are the kind of questions that will inform the design of the wastewater surveillance network. When we put the data together from our wastewater testing with the data that comes out of the clinical surveillance program in the country, we can make informed assessments about the extent in terms of the geographical location and the time periods in terms of the epidemiological weeks where the vaccine preventable diseases are likely to be occurring. And that can inform public health decision making. So the answer is that it is a country-specific and a context-specific approach that we will adopt in guiding countries to link both the clinical and the environmental samples. So what we do in South Africa is we have health districts allocated to, or at least rather the other way around, we have the whole population is divided into 52 health districts, and we have a wastewater testing plant or in about 36 of those. And we are able to speak to the agreement, as Mukhlid shared, between the environmental testing and the clinical testing. And if, for example, we find that there's no clinical testing, but our wastewater samples are picking up measles, then we need to inform the public health authorities in that district that in fact there is measles and they're not detecting it. So it might be different in different countries, and the results of the in-country assessment tool will guide us as to how to support the country to make a plan to link this up. Over.
Thank you. There's one more question. From your experience, are there any pitfalls that we should be mindful of as we try to implement wastewater surveillance? This is from Richard Garner. Being mindful that we are on top of the hour, Mukhlid, you can quickly take up that before we wrap up.
Well, I just wanted to ask from our team, Bongi, as well, to chip in here. She is a project manager and she has more experience to talk about the pitfalls. There's a lot of components in doing the surveillance from wastewater. There's a lab component, there's water side component. So Bongi, if you're still on the call, can you just give a comment about your experience here?
Just a quick one to say it's to look at the context. Thanks, Mukhlid. To look at the context and decide, you basically decide how you want the program to look and who are your key people, and you leverage off what you already have existing. That's makes, from an operational perspective, it makes it easy to get started. Then your key stakeholders need to be on board so that you keep going. But you need to leverage off existing systems where those exist. I don't know if that answers the question.
Thank you, Bonge. I think more context and discussions would be forthcoming during your direct engagements with each of the 4 countries. I believe this has been a very good discussion, very great presentations, and we can bring this meeting to an end. Just to let the 3 countries, Ghana, Nigeria, and Gambia, know that EXA will be reaching out to you starting next week so that we can start direct planning engagements with the NICD team in South Africa. That will be key to informing the next steps and actualizing specific timelines to the overall plan that Mukhlid did share with us. It was a great having all of you, and I want to give a minute to Fatim to give us final and closing remarks. Fatim, please welcome.
Hi, good afternoon, everyone. And also thank you so much to the NICD team, the EXA team, but also to the Global Fund team for putting this up together. And also special thanks to Tony, part of the lab team that really was instrumental in this. So I just want to also inform the NICD team that it has started. It's starting right now. So now the ball is in your court to really liaise with the 3 countries. You will have their email addresses, their contacts, and we should start. We're already delayed and also with EXA. So you'll have open communication moving forward with EXA and with the 3 countries. Just let us know reports on after the assessments, and I'm really looking forward to the reports of the assessments, such that we can work with the country as well as the country teams to really fast forward and move on with the procurement, which we know usually takes time, such that it will be ready by phase 3. And to the countries, as you see, this is a very technical, hands-on project or training. So if you're not involved in wastewater, if you will not use wastewater or you will not be involved, please let us know now, such that we don't waste the resources. We believe that those that were selected from the 3 countries are those that will actually work on implementation. And I'm happy that there was a question on pitfalls. And if there's any issues regarding implementation that you envision, please raise it very early with your country teams. They're there to support. They all know about this and they all agreed to this. So if there's no funds, which I don't think will be an issue for these 3 countries, please raise it to the country team, such that in case savings are identified, they could consider whatever comes out of these assessments. So I think for me, the most important thing is ensuring we have the right people that are joining this training. And also, you need to be involved from the very get-go, from phase 1 to the last phase. You can't come in between phases or drop off and come back on. And these are things that we will be monitoring and talking to the South Africa team, because we want this to be very impactful to the countries. So 100% participation. We will support you in implementing, in starting whatever is needed. So please, let's keep an open communication. There will be a community of practice that will be established. So it will be also important that you are part of that community of practice. And just let us know as we move on and what is important. If you feel you were included in this and this is not something that you will be interested in implementing in countries, it's fine. Please let us know, and let us know who will replace you in this. So with that, I again want to thank the countries, Gambia, Nigeria, as well as Ghana, for their involvement in this initiative. And we look forward to impactful results. And like Mokhlet said, presentations at international conferences or peer review articles, or even working towards your degree. I know some of you are using this towards a degree program, which is really, really exciting, and we really encourage it. And thank you so much. Bye-bye.